Right, welcome to Leadership and Culture in Healthcare. I'm Matthew Wynn, podcast host, and we have come to the end of Series 8. Series 8, we've been listening and talking to people who have started campaigns, mainly from terrible care, terrible instances of loved ones who have died, and people have turned that into phenomenal campaign elements. And I'm delighted to be joined for someone who's going to help us just think about those themes a little bit more deeply is Shaun Lintern. Shaun is a campaigning, investigating journalist. Shaun, why don't you tell everybody who you are and what you do so they kind of get that to begin with?
Yeah, thanks, Matthew, and it's a pleasure to join you on this podcast. I'm Shaun Lintern. I'm the health editor of the Sunday Times. I've been with the Sunday Times since around 2021, and prior to that was at the Independent. And then for many years, many of your listeners may know I worked for the Health Service Journal in a variety of roles, but largely focusing around the patient safety world and care scandals and kind of holding a mirror up to some of the darker sides of the health service. And the reason for that, and I often say to people when they ask me how I got into this, is I describe myself as an accidental health journalist, in the sense that this was never a specialism that I was particularly seeking. In fact, I remember actively discussing with colleagues I didn't want to go into health. I wanted something sexy like crime or politics. And I've since learned there's a lot of crime and a lot of politics in health, and I love the beat. But I got into it because I was working in a local newspaper in a town called Stafford when concerns started to be raised about the local hospital there, and I worked with families as a local newspaper journalist, helping them to expose what became the mid-staffs scandal. We campaigned as a local newspaper for a public inquiry, and I covered most days of the inquiry, and as a result of that ended up sort of becoming de facto health correspondent for the paper. And so I've been a journalist for around 25 years, and a specialist health investigative journalist for about 15 years. So I'm starting to feel a little long in the tooth, if I'm honest with you. But I think that's meant that I've seen a lot of things come and go, and quite a few things come back around again, which I'm sure we might discuss as we go forward in this.
That's really interesting, because you then got that much broader perspective on lots of healthcare. It's not just the NHS, it's healthcare more generally. And in our episodes, Jessie's rule with Andrew Brady about her daughter who died, sepsis reform with Melissa Mead about William who died very, very young, John's campaign, and then with Paula McGowan on Oliver McGowan that turned into that kind of fundamental training. All of them, Shaun, which I guess you're really used to, have litanies of errors that I think when I listened to each of those episodes, all of them were preventable and nothing got in the way of stopping that, and therefore the deaths that happened. And just give us your perspective on, you've been, as you said, 25 years looking at these things. When you look at organizations, when you look at things that have gone wrong, there's an inquiry I think you're covering at the moment in Nottingham about the maternity scandals that have happened there. When you look in, what do you think are the kind of ingredients that means organizations and then individuals in those organizations start to make bad decisions that have terrible consequences for the public?
So we're starting with the easy questions, Matthew.
Might as well.
Well, I mean, there's a lot to unpack in that question, and I think one thing that I've come away from the various scandals that I've reported, and in fact, most of the episodes on your podcast, I've written about them and interviewed the families involved at various points. But each scandal is specific and different to ones that came before it in the very specific failures. But there are as you rightly ask about sort of core ingredients. And I think, you look back over your episodes that you've spoken with families about, and you look at the kind of um, the systemic nature of some of it. What it boils down to, I think, is really a failure to listen to the family and the patient sometimes as well. Very often the patient when they're raising a concern, and I think what we've stumbled into as a system. People are under, immense pressure in the health service, that whether you are a frontline clinician dealing with, an understaffed ward and an overly bureaucratic paperwork system that you've got to navigate for each and every patient, or you're a manager or a clinical director or even a board level member trying to balance your targets and finance. A lot of this stuff just adds up to a huge cognitive load on people. And I think in certain scandals, what you see is a sort of a drip, slow sort of deterioration in the organization's focus on the patients, and they become, a little inward looking. They start to develop, there may already be elements of toxic behaviors in there, the wrong kind of people, and this can add up to something that just means, listening to a patient might mean more problems. It might mean more paperwork, more work. It might mean your manager brings, you're bringing a problem to a manager's door rather than a solution. Your targets might start slipping. All of this is playing in people's minds, and we've got to, people are trying to navigate this system, and if patients don't always fit the system. And so sometimes you get the, very obviously with Oliver McGowan, and with William, as well, that they were just not fitting the box that the clinicians wanted to put them in. And so there are very simple mistakes there that then lead to a mistake, an error. And then I think what we see in a lot of scandals is the response to that is a sort of institutional defensiveness. And again, it comes from the culture of the organization. If it's under pressure, if it's feeling attacked, if it's feeling, there's multiple difficulties that it's got to try and navigate. And so leaders then start to try and think about how can they avoid this becoming a problem. And it amazes me that we still see it so often, that people, by trying to avoid a scandal and a problem and admitting something went wrong, they almost actively create what they're trying to avoid. And that's where you get into the kind of cover up nature of it. And I there's only been a few instances in my career where I think people have gone into something actively seeking to cover it up. I think what I've seen is often a lot of accidental cover-ups that then become layered on and built on, and to the point where the organization cannot move away from the story that it's told itself. And so it has to be dragged there by, bereaved families and hurt patients and journalists getting involved. And so much of it could be avoided, I think, if we got back to listening to the patient, honesty when something went wrong, and then sorting that out instead of a defensive response. And I think, I'm oversimplifying every story I've ever written here, but these are the kind of core things that I see. And this is about leadership, as you've mentioned, and I think leadership at the top is core to why a lot of these things go wrong. But it's also leadership on a sort of more fundamental level, leadership of a ward, leadership of a team, leadership of a single shift. Those levels of leadership matter almost just as much as the leadership of the chief executive when it comes to responding to something that's gone wrong in the right way. I hope that answers your question.
Yeah, it does in part, and you've brought out two really key things, aren't they? Listening, taking family or patient views at heart. I'm going to come back to that because it's something I'm passionate about and thinking more and more about it at the moment. And then that organizational response. So let's just start there, because I was really struck by Melissa Mead's reaction to trying to understand what had gone on with William, because actually all she wanted was why. Why did the decision making happen that William that what was going on with William wasn't identified and something had done about it. And I heard her talk about the both the general practitioner, but the organization and then the integrated care board as it was at that time kind of get clouded in legalities of we can't disclose this, and we're clearly worried about litigation, whereas Melissa was looking for answers. And you've no doubt seen that quite a lot, where we I think people get very confused about transparency and the duty of candor. It should just be the fundamental principle. If their legal process happens, so be it. A legal process happens, but actually we shouldn't shy away, and we shouldn't erode that whole element of we need to be honest about what's happened, even for a process that follows. Easy to say. What's your perspective on that? Because it's pretty hard to do, I guess.
Yeah, I mean, it's really interesting because, I mean, you're absolutely right. Families want answers. And in fact, I don't think I've ever, and I mean this genuinely, I don't think I've ever sat down with someone I've interviewed and they've not said to me, the only reason I'm taking this down the legal route and suing the trust is because I want answers. You know, it's never about compensation or money, which incidentally is a good thing because the level of compensation we pay in this country is actually appalling.
Mm.
You know, if you the price we put on a dead baby, for example, is
It's
in my
terrible.
view
Yeah, yeah,
awful and insulting.
yeah.
But so this isn't about money, and you're right. The duty of candor on the organisations is there, and that's a good thing. It's something that came from mid staffs. It was not put on at an individual level. We'll see that perhaps change with the proposed Hillsborough laws, and that's possibly a good thing and long overdue. But I think, you know, you talk to NHS Resolution that handles the clinical negligence claims for the NHS, and they're quite clear that saying sorry to someone and explaining what happened is actually not something they would, you know, warn trusts against doing. And yet there is
Mhm.
this perception that if trusts do that, they're going to, you know, open the legal, you know, floodgates. And genuinely, I think almost all the cases I've dealt with, if that had been more forthcoming, um, these things wouldn't have developed in the way that they did. And I think we have to pause and say, you know, there are lots of occasions where this is done properly.
Mm.
And you never hear about them because I don't report them because they're not news, because it's not, you know, it's the NHS doing the right thing. And I remember once I had a story, a maternity story actually, at the Health Service Journal where um, a trust, and I'm afraid my memory is failing me and I can't remember the trust now, but a mother contacted me and I instinctively thought, here we go, another big, you know, maternity scandal. And actually, the trust had worked with the mother. There had been a proper duty of candor process. The mother was satisfied that, you know, she had sued the trust and had a payout, but she had, you know, worked with the trust to get to the position where she felt she could hand over the issue and let it go. And we did one story, which was a positive in a way, a positive story because the mother's comments about the trust were positive, and the trust was able to say, you know, we've taken on this case and we've learned, and you know, we're very happy. The family are happy, and you know, we've reached a settled position, and we're going to do our best to prevent it in future. It was one story. Now,
Mm.
if you
Mm.
had removed that trust's response and they'd taken the response of say Shrewsbury or Nottingham and denied everything and covered things up, etc., I would have embarked on, you know, a multi-story
Mm.
coverage of this.
Mm.
So, yeah, I just make that point that there are occasions where this is done well and we won't know about that. But I think, you know, there is no reason for trusts not to be honest. And if more were, I genuinely think we would see far less anger, far less campaigns, you know, far less vitriol um, actions by families. Because ultimately, these families don't want to be in the position they're in. And almost all of them universally will say the same things to me in every interview, that they
Mm.
just don't want it happening to another family. So it's something trusts have really got to work at. Duty of candor is not something you can just say on a piece of paper and be done with it. It actually takes some real thought. And I think this is where real leadership comes in at the trust, at the senior level. The chief exec needs to make it clear, this is my position. And whatever the trust lawyers try to advise, ultimately the decision is for the chief exec, for the trust board, and transparency and duty of candor will, I think, stop a lot of scandals from ever becoming, something that I have to start thinking about and start contacting you about. And it's a shame
Yeah.
that we haven't quite got that culture right yet in the NHS.
No. But help people understand, you just made a differentiation, Shaun, between the duty of candor at the organization level as opposed to the individual level. Help people understand that distinction, both in law and in that awareness of what that means.
Yeah, so when Robert Francis produced the public inquiry report into mid-staffs, there was during the hearings, there was a lot of different debate and evidence from people saying, it's time to have a duty of candor on the individuals. And there have been other families who've long before mid-staffs arguing for this as well. And people want that duty applied to individual staff, so that individual staff have to be honest with patients when something's gone wrong. The amazing thing was, and it sounds kind of weird now to think about it, but there was no duty on an NHS trust to be honest with a patient when something had gone wrong
Mm.
as an organisation. And at mid-staffs, we saw huge numbers of dishonest representations and cover-ups of individual cases. So Robert Francis made this recommendation. The government accepted it, and it places a duty on the organisation that where an incident, a serious incident, causing serious or moderate harm has happened, the trust is under an obligation, a legal obligation, to tell the affected patient or their family, involve them in the investigation process, and make sure they've got full written explanation when that comes to pass. Yeah, and that is done. I've seen it work well. I think people still don't really understand it at a organization level. Still, I still see rather odd tick box approaches, and families still not actually involved in the investigation process. But we've moved a long way from where we started with. I should mention, of course, that if you're a nurse or a doctor or another registered, professional, you do have your own professional obligations to be honest with patients and transparency. But we don't yet have a sort of similar duty of candor for staff, although government are talking about that. And I think that's important because we do see examples of individuals making decisions that hide information from families, and an organizational duty will only work if individuals in that organization are following the same path. And I think it was perhaps inevitable after mid-staffs that we would end up here, but I think it's interesting that it's through another mechanism, through another civil society scandal, that we're having this hopefully imposed on public servants. But we need to see the detail, and but my hope is that it does apply to every senior leader in the NHS, because they're the ones making the decisions about how duty of candor is actually used. So it's yeah, I should say as well, if you breach duty of candor, technically it is it is a breach of regulations of the CQC. You can be
Yeah.
fined and prosecuted by the CQC for a breach of duty of candor. Not that they do that very often, and it's a relatively small fine. It's not quite as serious as some of their other regulations, where you can be dragged to court and fined millions of pounds as an organisation. It's not quite the same for duty of candor, but
Mm.
it is there as a marker that if you could find yourself on the wrong end of a CQC intervention.
Yeah. I think it's interesting when I listen to that. my first reaction is, "Oh, isn't it sad that we're having to put that into primary legislation to emphasize that we should be honest in our affairs at an individual level and not just at the organization level?" But I had the same thoughts about as I was doing the episodes. It's actually very sad that we've got any of these campaigns, because they're all campaigns about the basics. Their
Yeah,
honesty, their bring recall, their access for carers to their loved ones in a bedded care unit, whether that's the care home. You just, when you step back, you just go, but these are normal expectations we should have. And it's just, I think it's just remembering that, isn't it? That actually fundamentals of care done right actually is the basis of all this, but we're
yeah,
having to litigate against variation to that and organizations and individuals that just won't do the right thing.
absolutely. And I'm remembering just talking to you now, Matthew. Robert Francis, when he um, launched the public inquiry report back in 2013, he delivered a written summary, or he read out a summary of his findings. And I always have said to people in the years since that I think it was something like a 9-page document, this chairman's summary statement. And I've urged, everybody to read that, not the report actually, because I mean, you can obviously, and you should, if you're in a senior position in the NHS, you should have read it. But if you've never read anything to do with mid-staffs, read that summary. And if anyone can't find it, get in touch with me because I've got it. And what he said in that is still true today, really. That yes, he was talking about mid-staffs, but what he said was this was a system that had forgotten its core business, which was the patient. It had moved
Mm,
away from that care by dragged there by politics, by financial concerns, by policy targets and waiting list targets, and the foundation trust pipeline and a myriad of things that maybe not distracting people now, but when you distill that down into its core message, I'm not sure we've actually taken the lesson from that. And I can see as we look around the system now, a massive reform, a bill going through Parliament, the Foundation Trust pipeline being resurrected from the Lazarus pit of policy at DH. And here we are again, where it's very easy to see how the system could be distracted by everything it's got to deal with and forget that fundamental
yeah.
business, which is providing care to patients and listening to patients and doing that thing. And it's so easy for me to say, sitting here as an observer of the NHS, but that to me is a fundamental thing that I still see that tension play out in a lot of these stories.
Mm. Yeah. And just for listeners, just to full accountability, my organization is going through the Advanced Foundation Trust pipeline that Sean's just referenced. But it's interesting, just on a cultural aspect, my critique of, and this is getting a bit policy wonky wise, but my critique of foundation trusts as they were originally was essentially that they were there to make themselves good, and success was only for their own organizational benefit. The Advanced Foundation Trust is policy wise, is you are successful when you are improving the outcomes of the local population and are a good collaborator. It is a really helpful distinction, I think, and a helpful move, because ultimately statutory organizations are public benefit organizations and we're public servants. We're not businesses that are driving a profit line.
Mm. Yeah, absolutely. That's an interesting point. And uh, I'm really tempted to start asking you, Matthew, how much work is it taking to go through that process, and is
Another
it distracting
podcast,
any of your
yes,
staff?
yeah.
But yeah, but these are the things we need to think about, right? There are
Yeah,
all sorts of
yeah.
things that organizations are having to deal with. And I think, as a journalist, it's very easy for me to bash managers, and perhaps we'll get on to manager regulation at some point. But actually the evidence is pretty clear. The NHS probably doesn't have enough good managers, emphasis on the good. And maybe that's the problem here, is that we're expecting a shrunken cohort of manager class who've not been supported, trained, or given the skills to actually do the job. Some of them, certainly, nurses end up in management almost by accident without any real support or training when they get there. And we expect them to do all of this stuff that comes down from Parliament and campaigns and all the vested interests, the charities of all colleges, everything they have to deal with, and then we expect them to still be able to keep the fundamentals and the show on the road. But are we giving them the tools to do that? I mean, I think there's a genuine debate about whether we are setting the system up to fail, actually.
Oh, I'm going to come back to that, but I want to just dig into the other point that you made at the top, to my question about, and it was about failure to listen. And you said, there's lots of reasons why failure to listen. And I think going back to the episodes, all of them had huge issues that people, either the person at the center or the family member who knew the person really well, especially Melissa Mead with her very young son, were not taken seriously, and their word and their direction with Paula McGowan was not taken up by the clinician. That that on one level is unforgivable, isn't it? But I see it regularly. My dear father recently passed away. He was 96, and I could see that people, when I said he doesn't want this, or he has already stated it doesn't want this, it was almost the start of a negotiation rather than a definitive point of that has consequences, and therefore you should stop treating in these scenarios, as it was with him, because he was very frail and didn't want active treatment. You must see this all the time as underpinning lots of scandals. What's your observations on that in terms of culture and approach?
Yeah, well, I think sorry to hear about your father, Matthew. And I had my own experience last year that my mother died in November. She was diagnosed with motor neuron disease in March last year, and died in November. And I was her main care coordinator. And motor neuron disease is probably the worst thing I've ever experienced in my life. And but what I saw was a really interesting perspective, because my mum got great clinical care at the point the nurse was providing it, or the doctor was providing it. When I was able to get the clinician and my mom together, everything was fine. uh, the problem I found was the coordination around the patient, the organization around the patient, and listening to me as her sort of voice. We're often not listened to by a
Mm.
lot of people, and there was a lot of process. And I think this boils down, to answer your question, I think what we are in real danger, I think, of having the taskification of care going on. And Professor Alison Leary from LSBU has talked about this really well. We are seeing this kind of standardization is a good thing. Everybody should have standards. We have guidelines. We're creating systems for staff to use. But what it means in practice sometimes is that the staff member has to work through their protocol, but the patient doesn't care about that protocol, and patients don't necessarily fit into these easy boxes that we've maybe created with the right intention of
Mm.
standardizing care. um, and I don't think there's anything wrong in that approach necessarily, but have we properly created a culture within the staff and the frontline workers to use that protocol in a way that is actually flexible and malleable to the patient in front of them? Or have we just grafted on multiple layers of systems and processes that the staff just have to kind of squeeze the patient through? And that leads to all sorts of tension, frustration, cognitive load, and difficulties in the day-to-day work that they're doing on the wards. And I don't know the answer, but is that a reason why people say communication is their biggest issue and complaints against the health service, and that all the scandals that we talk about, people weren't listened to? Is that why?
Mm.
I mean, there are obviously the cases where you come across where people are just, cruel, to be honest, where they are, racist, where they are reckless. I mean, we shouldn't forget that those cases do exist. And, Professor Mary Dixon Woods has talked about that we do need to talk about bad apples in the
Mm.
NHS. I do hate it when people come up with the trope about nobody goes to work to do a bad job. Nobody goes to work to do consciously to do a bad job, but some people are reckless as to whether they do a bad job, and some people become, uncaring because of whatever else is going on in their life or their work. So we shouldn't forget that as well. But I think there's a big issue around listening, and I think we need to be thinking about that as a system design, and I don't think we do really at the level that where these things are introduced. And I can actually see a growing move towards taskification rather
Yeah.
than away from it. Certainly, as we have a differentiation of staff. Whatever your thoughts are about junior doctors becoming more expensive for their pay rises, the inevitability is that we're going to see more, advanced nurses, more staff, almost every class of staff now has a sort of cheaper, lower level trained member of staff below them who are taking on some of the roles and some of the work that those above them did. And you're seeing that this taskification, the healthcare assistant will do the obs at the bedside, tick their box and walk away. But because they're not a nurse, they're not doing they're not chatting to the patient, they're not looking at their skin, and they're not listening to the answers and deciding whether or not there's a cognitive issue that's suddenly come to play, or all the amazing things that nurses do when they're talking to a patient that you don't do if you're just that your job is just to go around the ward taking the basic obs and putting that into your
Mm.
handheld device. I'm probably oversimplifying things, and all your listeners are going to be screaming at the podcast right now. But I hope you get the point I'm trying to make.
Yeah. And at the heart of that, delegating tasks and delegating processes to people, especially who are non-registrants, actually doesn't abdicate you from the responsibility. And what you're describing is people that therefore are not then looking in and looking at that holistic way and saying, are we still doing the right thing here? Are we supporting? I I think my other perspective on this, though, and it comes out to personal experience as the chief exec and from personal life, but also from this series, is we're not great at defining risk in terms of the individual preference as opposed to our organizational risk. And
Yeah,
Sheila Reardon, who's the president of the Hospital at Home Society, actually on a previous podcast spoke this really well. Says, I think she said something like, just because we can do something doesn't mean we should. And she was talking about people who are severely frail. And that was that whole element that risk needs to be about my preference and my choice. And therefore, I think it's a really tough thing then to change all our protocols and policies to be flexible enough to be not rigid, as you just
yeah.
described, but have that kind of flexibility at the edge to say we will do things defined by the people that we serve, not just our own organizational viewpoint on that. That's actually quite a tough balance, I say.
Yeah, definitely. And I mean, I can already see the risk and the challenge for organizations in doing that, right? Because
Yeah.
you'll get it wrong for one person, and you'll find yourself with a complaint and someone running off to the local media or even to myself. But I think you are right though that we do need to have a better understanding of risk, both on the NHS side, but also patients as well. We need to understand that and think about what we're asking of the system. And you talk about risk. I mean, I remember when my mom was in hospital last year to have a peg feed fitted to help her get nutrition because the MND had taken her ability to eat. We were told that would be a 3-day admission, in checked, up on the second day, observed overnight, out on the third day. By day 15, I had gone to the discharge manager and I'd said, "You are this close to me writing an article for the Sunday Times about the NHS kidnapping my mom because she didn't want to be there. She was finding it incredibly distressful. She hated being in the hospital. And actually what we found was that it was an aversion to risk which was keeping her in. So somebody had made a referral to speech and language inside in the hospital, which meant the discharge team couldn't touch mom yet because that process needed to be resolved. But she had a speech and language team out in the community.
Outside, yeah.
Same with dietitians. And then best of all, on a Friday, she had a scan to make sure the peg was in the right place. And junior doctor said, it looks fine to me, but it needs to be signed off by a consultant. And it's 6:30 on a Friday. They're not back until
available.
9:30 on Monday. And so my poor mom languished in an acute ward at University Hospitals Midlands, and over the weekend when she desperately didn't want to be there. And that was an unnecessary thing. There were multiple reasons why mom could have got out of that hospital, and it was, I boil it all down to risk aversion and a sort of blindly following a process and not thinking about the patient in front of them. And actually, had a smart doctor just come and said, "Are you happy to go home with these risks? This is why we would keep you." But actually, common sense says, I think both me and my mom would have said, "Yeah, let's go home."
Let's go.
Less
Risky for her.
But it just wasn't possible, and it's so frustrating. And I think that multiply that across the country every day, 1 million people every 17 hours seen by the NHS. That's probably higher now. You can imagine. When we talk about the system being sort of bunged up, that probably explains a lot of it.
Yeah. Well, let's just change tack for the final bit, Shaun. You went into manager, the professionalism of managers, the number of managers, the oversight, and whether they will go into some regulation. Interestingly, from all of the episodes that I have done in this series, most of it wasn't about the organizational response or about, apart from not getting to understand the legitimacy and the truth of what went wrong, most of it was around how organizations weren't supporting their clinicians well enough, which meant that they were making mistakes because of the issues around them. So would you put that into the same package of mandatory regulations, that actually it's a core responsibility that the ingredients of great care has to happen, and that's part of that regulation in that respect?
Yeah, definitely. I mean, I think I've long advocated for regulation of managers, and people will respond to me. Very very well-known, thoughtful people will say this is a terrible idea. It never prevented any scandal. Regulation of doctors hasn't prevented scandals, etc., etc. And that to me is a fundamentally silly comment, because proper regulation, is not just about striking off a manager and preventing them ever working. Tom Cark, who incidentally was chief counsel to the mid staff's inquiry, was asked to do a report into all of this. And I think he produced a really good blueprint of what professional management of the NHS should look like. And, when I talk about regulation of managers, I'm talking about creating a professional class who are, trained, educated, and supported to do that job against proper standards that they can follow and implement, that they know what is their core duty and role and responsibility. The stick, if you like, comes at the very, very end of a very long process. And
Yeah.
we're talking about the absolute worst scoundrels who've somehow, found their way into the management class. And we know those people exist. We know they do. And we need to have a mechanism to prevent them making full use of the revolving door and popping back up, as many have over the years. But that is really it's a very end of afterthought of regulation. because what I really want to see is leaders properly supported, trained, and able to actually lead these organizations. With NHS trusts are massive organizations, hundreds of millions, in some cases, some of the biggest, over £1 billion in turnover. They are largely the biggest employer in a town. These are highly complex organizations. And the idea that we put someone through simple graduate management training, or at the very least, they fall into this by accident over time by just rising through the ranks with very little support or training. I think it's no wonder we get into all the problems we get into with the NHS. Not just scandals, but things like patients being found in a drawer and waiting lists being changed, and targets being gained, and all of this stuff that goes on that is harmful to the NHS as a body. This happens because we don't have that professional management class. And if you go to a local lawyer or solicitor and you ask them to do something that they can't do through their standards, they will proudly turn around and tell you that I cannot do this, but I'm not allowed to. And it makes a difference. And I think, we need to grasp the nettle on this. It is going to happen at some point. And most managers I've spoken to, most chief execs, when I've explained to them what I think regulation of managers means, most of them turn around and say they'd welcome that, because there have been times where they've been asked to do something where they would have really wanted to turn around and say, I'm really sorry, but I can't do that. I just cannot be allowed. That is against my professional code and standards. And I think, we need to have that debate about proper regulation. I think we've got stuck into this, and maybe this is my fault as a journalist and the media's fault, but we've got stuck into a debate between no regulation or striking off failing managers. And there's a whole thing in between that we've not discussed.
Yeah. And all our professional bodies for regulated clinicians would mirror what you're saying. It's all their, the vast majority of their work is on making sure people are great at what they do and sorting out curricula and making sure training is defined to actually say this is what a great clinician is. I do actually, I do find it odd. The only serious disagreements I've had with a consultant level have been about adherence to standards, and someone arguing with me many years ago that they wouldn't adhere to NICE guidelines. So my response was, of course, well, you show me the guidelines you're working to, you write them to the same standard that NICE guidelines are held to, and get the medical director to sign them off, and then I'm happy for you to follow that. It never happened, and we adhere. But if the counter back to me is, well, what guidelines do you operate under, Matthew, as the leader of the organization, etc.? It's a good challenge, and I could probably articulate it, but I shouldn't need to make it up to say that's the ethos and culture I like to have as a leader. It should be something more definable, shouldn't it?
Absolutely. And when you stop and think, as I said, the NHS organisations, hundreds of millions of pounds turnover, biggest employers in local towns, and yet the door staff on the local nightclub are more regulated than the chief executive of the local NHS trust. That to me is an unsustainable position.
As the taxi driver for taking people home. Yeah.
Well, exactly. Yeah. So exactly. And so I just think it's unsustainable. We're going to need to deal with it at some point. And I think a brave government could adopt it as a kind of, we are going to inject some humanity back into our NHS. We're going to emphasize duty of candor, listening to patients. We're going to get managers focused on the right things, trained and supported, with a stick at the very end if we need it for the worst of the worst. But there's a whole program of work that could be done to do that, to tackle all the things we've talked about this morning. But it would need some bravery, and I'm afraid we just haven't seen that in the last 15 years I've been a health journalist.
Yeah. All right. Last thoughts then, Shaun. You've got the 5 episodes that we've talked about some of the big chunky issues that come out of that, about culture. We talk about not listening, organizational defensiveness. You rightly have kind of pushed us, and we'll get it in the summary notes for the podcast, about Robert Francis's summary judgments about doing the basics right and get it right, not have tarsification, actually ensure that actually we have a a set of equipped leaders to actually be great public servants, to lead these really tough organizations. What this may be a territory you might not want to go into, but what are you optimistic about when you look at this world, when you look at the healthcare world that you spend a lot of time often in the dross? Where can you point to say that gives me optimism about getting this stuff right?
Yeah, so it's a good question actually, because you know it's a thing that's often directed towards me as you, it's overly negative, overly critical, etc. And of course I am, because that is the role of a journalist. My
Yeah.
job is to hold up a mirror. So if I'm writing about it, that's because it's extraordinarily bad. It's not because that's how it is everywhere. And actually, I do see good work all the time. And if you go onto any hospital, there's great care happening all around you. We know that. It's true when you look at the inpatient surveys and all the rest of it. Of course, there are always things to improve, but we know that generally patients are getting good care. And there's so much to do to improve the NHS, but I would rather be here than anywhere else on the planet receiving
Mm,
healthcare.
mm,
And when I talk to, I met with some advanced nurses working in a specialism recently, and they were just so enthusiastic and on their game and wanting to make really good change. And I think, yeah, whenever I spend a day, and I don't do enough visits actually to hospitals. So anyone out there wants to offer me a visit to their hospital, come and get in touch. But
or
I
any
do
other
love it
healthcare,
because
any healthcare setting, not just hospitals, Mr.
absolutely,
Linton. Yep,
absolutely,
yep.
yes, yes, yeah. I mean, I'm all up for doing visits, but every time I do, I come away enthused by, what I see. We've got a lot to do, we've got a lot to improve, but there's so much great stuff going on. And I think at the moment, areas around genomics and all of the sort of cutting edge developments are really going to change people's lives. But actually, when you look at the sort of the movement towards community care, which I know is obviously close to your work, Matthew, the work that goes on actually closer to people's homes, when district nurses go into someone's house. If you do a shift with a district nurse and see the relationship they have
Yeah,
with patients, it really does, build your humanity up from in the inside. It's wonderful to see. And
yeah,
I did a 12-hour shift with London Ambulance Service a few years ago, and similarly seeing them out on the ground, if you like, in the community doing their work. It's there's a lot to be thankful for with the NHS. There's
mm,
a lot to be grateful for. It is I think one of the best health systems in the world, one of the best models we could have. uh, it could be so much better, and
yeah,
that's what motivates my journalism and my
yeah.
writing. It's to push it further, and we've got to keep going on that.
Well, Shaun, on the thanks, I should just say thank you to Chris Poynton, Andrew Brady, Melissa Mead, Julia Jones, and Paula McGowan, who were very gracious in spending time with me, as you have, Shaun, in just discussing these things, because actually, I think you've just summarized it really well. Great things happen every single day across healthcare, both in the private sector and the public sector. What we need is the basics to be right everywhere all the time. And I'm sure everybody listening will be relying on you as a great journalist to be putting that mirror up, shining that light into areas where it doesn't go. And I say this with all affection. I hope you come nowhere near my organization nor ever need to be, but I enjoy your leadership and your journalism. And thank you for spending time with me on leadership and culture in healthcare.
Thanks, Matthew. And just as a message to everybody, I need more positive, good stories. Please give them to me. It's difficult to get them out of the NHS, so I'm very open to those. But it's been a great podcast, and you've had some great guests, many of whom I've
Yeah,
spoken to over the years. So
I'm sure.
thanks very much for your work.
Right. Thank you, Shaun.